Next up, we have Dr. Tasanee Braithwaite. She is a consultant ophthalmologist at Guy's and St Thomas's NHS Foundation Trust and lectures in ophthalmic epidemiology and health informatics at King's College. She's had a long interest in sarcoidosis and its impact on the eye. It's estimated that half of all sarcoidosis patients experience some form of eye problems. It's a few years since we last covered this at a patient event, so I'm delighted to hand over to you. Taz.
Perfect. So good morning, everybody. Thank you so much for having me. It's a real pleasure to have the opportunity to share some time with Sarcoidosis UK and with this group of people who are invested and interested in trying to understand more. And I hope that if you have questions, I'll be able to answer those as we go through. So I'm a consultant ophthalmologist at Guy's and St Thomas's. I work equally between neuro-ophthalmology and uveitis and scleritis. So I see sarcoidosis presenting across a very broad spectrum in a very broad spectrum of ways. And I'm also a clinical academic, and I spend half of my time at King's College London trying to advance research that has hopefully positive implications for our understanding of how we diagnose and manage sarcoidosis, amongst other diseases that can mimic it. So today I'm going to talk a bit about ocular sarcoidosis and how it affects people's eyes, what you feel, what we see. I'm going to touch on the treatment options and on managing the side effects and complications. I'm going to talk about some lifestyle adjustments that patients can sometimes find helpful and touch on the outlook for vision. And then I'm going to tell you a little bit about the sorts of research that my team are doing and answer your questions. So we're amazingly lucky in ophthalmology that we now have this phenomenal array of imaging modalities that give us unremarkable insights into how the tissues of the eye are functioning. So many of you, if you have ocular sarcoidosis, will be familiar with the sorts of images on the left-hand side. We have optical coherence tomography, which in the pictures in number C on the left allow us to take cross-sectional pictures on the inside of the eye that give us remarkable insights into how the optic nerve and the retinal tissues and the tissues of the choroid are functioning. We can image the blood vessels in amazing detail. So in picture D, you see an optical coherence tomography angiogram that gives us this remarkable detail down to the level of individual capillaries and how they are functioning at the back of the eye, in the part of the eye that's most sensitive to damage and most important for seeing clearly in the distance and at near. The picture at the bottom, picture E, shows us a cross-section through the back of the eye in the part of the eye called the macula. And again, this is this part that we need most importantly for seeing clearly. And we have other imaging modalities. We can inject dyes into the veins that allow us to see more clearly the retinal blood vessels. That's shown up in white in picture B at the top. And we have imaging called autofluorescence, which allows us to see how happy or unhappy the cells of the retina are. That gives us clues into disease and risk of vision damage and scarring over time. And on this picture on the right, this schematic picture of the eye in cross-section, I've put it here because really sarcoidosis can affect every structure in some way or another in this picture, or the complications of the treatment can affect it. So it's, you know, I mean, sarcoidosis can just go to any tissue in the body, and that's very much the case for the eye as well. So I've got a lot of pictures coming up, and some people feel a bit squeamish about pictures of the eyes. I know my husband is one of those people. So if you feel quite squeamish about looking at eyes, you know, you might want to listen rather than look to the next pictures. Just, you know, I don't want anyone to feel uncomfortable. So moving on, it's quite common, top left, for people to get pink or redness of the eyes when they have inflammation. And we call this conjunctivitis when it's the topmost layer of the clear film that kind of coats the white part of the eyeball. We call it episcleritis when it's a layer deeper. And we call it scleritis when it's really the white coat of the eyeball itself that's becoming inflamed. So here in this picture on the top left, you see episcleritis. The hallmarks of episcleritis, it's very common in many autoimmune conditions, including sarcoidosis. It causes a pinkness of the eye, but the amount of pinkness is out of proportion to how it feels to the person. So often the person might say, I feel maybe 1 or 2 out of 10 discomfort. It's not really bothering me, but my eye looks quite bad in the mirror. And that helps us to understand that it's that layer of blood vessels that's a bit inflamed. And this settles of its own accord. It can be helped along by using regular lubricating eye drops. And it can come and go. Very occasionally we use steroid eye drops to make it go away faster, but really it will self-resolve on its own with no treatment, no intervention, just lubrication to help it along. And it can come and go, and it can be quite common. On the bottom left, what you're looking at is the cobalt blue light that we shine at an eye on the slit lamp. And the little yellow specks that you're seeing are where a dye called fluorescein has stuck to the surface of the eye because the eye is dry. And we see dry eyes very commonly in many autoimmune and autoinflammatory conditions, and we particularly see it in sarcoidosis. And you can feel like the eye is dry and it feels gritty and a bit sore, and the eye can be a bit pink, and you can feel like you're wanting to blink more often than normal. And sometimes with the dye, all we see is that the tears are breaking up a bit faster than normal. But in more severe dry eye, the little cells on the surface of the eye, which form a carpet, like a single-celled carpet across the surface, some of those tiny cells fall off and die, and they fall off, and the dye sticks to the layer beneath them. And we see that dye sticking here to these are little tiny clumps of cells that have fallen off because the eye is so dry. What you can also see on this picture are little streaks just to the right of the middle. And these are called filaments. And again, a dry eye will sometimes form these sharp, scratchy filaments. And this very much drives the symptoms of that gritty, sandy feeling in the eye. Dry eye can be very easily managed when it's mild, but some people really suffer from quite severe dry eye, and it can be pesky to manage it. And as we heard at the very beginning, sometimes one of the challenges of sarcoidosis is living with the chronicity, the long-termness of the symptoms that can wax and wane. And it's about finding a strategy that works for you. So if you do suffer from dry eye, there are various things that you can do. You can use hot flannels that you hold against the eye to boost heat to the little oil glands, and that can produce more oil and help with the natural lubrication of the eye. So holding a hot flannel against the eye morning and evening can be helpful. Gently rubbing the eyelids to try and squeeze out that oil onto the surface can help boost the natural lubrication of the eye. And then on the market, there's a whole plethora of topical lubricating drops. And there's a dizzying array of them. And they're all marketed quite heavily because they are produced by private companies, that are looking to obviously make a profit from their products. From our perspective, there's no clear evidence base that one eye drop works better than any other eye drop. They all contain magic different bits of ingredient. And I really think there's value in trial and error and finding what works best for you. Often what differentiates these products is the delivery mechanism. So some of them come in little vials, some of them come in bottles, some of them are preservative-free and some of them aren't. Some of the bottles work by squeezing, some of them have a kind of different mechanisms for releasing the drops. And people whose hands are of different strengths can find those bottles easier or harder to use. And I just think it's worth experimenting and keeping a list of the things you've tried, the things that you liked, the things that you didn't. Broadly, there are clear drops that are used in the day, and there are thicker, creamy, white, paraffin-based ointments that you use at night. And inserting those overnight can help just give your eyes a helping hand with just healing that ocular surface that you see looking a bit damaged in that bottom blue left picture. So many strategies to dry eye management. Sometimes in more severe cases, we put little silicone punctal plugs into the corner of the eyes. These are temporary little plugs, literally, as they're called, and they take a moment to insert at the slit lamp, and sometimes they fall out a moment later, but they can sit there for months or even years, and they just serve as a plug to reduce how much fluid flows off the ocular surface. They trap those tears on the surface, and they can help with those symptoms. And only in very, very extreme cases of dry eye are an escalation to other things considered, things such as topical immunosuppressive agents like cyclosporin, or even the creation of autologous serum eye drops. This is where we take a person's blood and we send it to a lab, and it's spun down, and the yellow part of the fluid that's left over is then returned and created as a product that's sent back to that individual person and used to treat very, very severe dry eye. Moving on to the pictures on the right, I see a lot of patients with uveitis. This is inflammation in the front chamber of the eye. And oftentimes in sarcoidosis, we see that these little telltale blobs form on the inner clear window of the eye, which we call the cornea. And we call these chorotic precipitates. And they are a clue as to the possible cause of the uveitis, because there are dozens and dozens of different causes of uveitis, and they present with slightly different patterns that we see as ophthalmologists. And that helps us to narrow down the most likely cause. So these are these granulomatous KPs, chorotic precipitates, that can give a clue to sarcoidosis. In the bottom right of the picture, we're looking at the black hole, that's the pupil in the eye, and we're looking at the muscle around it, the iris muscle. And on the rim and the edge of that pupil margin, you might make out these little blobs. I don't have a pointer, but there are little circular pale blobs just on the edge. And we call these iris nodules, and they are clumps of granulomatous tissue that's sitting on the iris surface. And there are very few conditions that cause uveitis that also cause iris nodules. And so that's a very helpful telltale sign for us in patients who have uveitis, that it might be sarcoidosis that's underlying it. Sarcoidosis can also go into the lacrimal glands, and that relates to the dry eye that I was talking about a moment ago. So your lacrimal glands sit in the upper outer aspect of the orbit. So they are above the eyeball, up in that top corner, and they produce the watery part of the tears, the aqueous part. And sarcoidosis can infiltrate those glands, and it can contribute to poor production of that aqueous part of the tears. And when I was talking about managing dry eye earlier, something else that's helpful to think about is that your tears are not just water. And so one of the worst things you can do, for example, is stand in the shower and open your eyes and let the water wash away all your tears, because your tears aren't just water, they're much more complicated. They're like a very complicated salad dressing. And to have a good, healthy, comfortable ocular surface, the tears need to have a good balance between the watery part, which these lacrimal glands produce, that's the aqueous part. They need to have the oily part, which the glands produce, and that's why heating the eyelids and gently massaging them and using hot flannels and cleaning the eyelashes can all help with the tear film, because they help boost the oily part. And they also have to contain a part of mucin, and that's produced by some different little goblet cells, some glands that also surround the lining of the eye. And these different components need to be in balance for the eyes to feel comfortable. And so enlargement of the lacrimal glands can be seen. Sometimes it can be so pronounced that it's cosmetically unsightly, and the person feels aware of how they look in the mirror because of a fullness of the upper lid. And it can be sometimes a very helpful first sign of sarcoidosis. Sometimes it presents in the lacrimal gland first before it's presented elsewhere in the body. And it's helpful for us because the lacrimal gland is a very easily accessible place. So a biopsy can be taken, and that can sometimes clinch the diagnosis. And importantly, it can help us to differentiate whether the swelling of the gland is coming from sarcoidosis, which is requires one sort of pathway of treatment, versus whether it's coming from something else. And there are many different conditions that can infiltrate the lacrimal gland. And so as clinicians, our first job really is to get to the bottom of what that causes. because those treatment pathways differ so much. And the thing that we worry a lot about is of misdiagnosing something as sarcoidosis when it's in fact lymphoma, which is a type of blood cancer, and it can look just the same. And so we spend a lot of time, and often it can delay the diagnosis, and it can delay the start of treatment, our zeal for trying to get to the bottom of the tissue diagnosis. And that's because if you treat somebody who's got lymphoma in the same way as someone who's got sarcoidosis, you can actually melt away the swelling for a time. And for a time, the person feels better. And you think you're correctly treating sarcoidosis, but what actually happens is the lymphoma, the cancer, comes roaring back, and the prognosis is then worse for the delay of the wrong diagnosis in the first place. So we never want to see that happen. And we spend a lot of time at the beginning trying to make sure we've got the right diagnosis of sarcoidosis before we start treatment. And the lacrimal gland can help us in that quest. Sarcoidosis can also cause a more nasty inflammation of the white, thick, fibrous coating of the eyeball, which we call the sclera. And so we call that scleritis, itis being inflammation of. And the inflammation can affect the front of the sclera. We call that anterior scleritis, and we see that in the top left here. Sometimes it's diffuse, it's all the way around the white part that we see. That's the top left picture. Whereas in the bottom left picture, it can form more nodular presentation. So you can get kind of more localized inflammation, and we call that nodular anterior scleritis. But scleritis can also affect the back of the eye, and we call that posterior scleritis. And here you see a picture of the inside of the eye and the wavy lines that can sometimes develop in posterior scleritis. This is a much rarer diagnosis. It's more sight-threatening because that disruption can affect the sensitive tissue at the back of the eye that I was showing you those lovely normal images of at the beginning. And it's a hard diagnosis because other conditions can look a little bit like this as well. And sometimes posterior scleritis can be painless, and that can throw us off the scent as well. So the hallmark of scleritis from the patient's perspective is that it's unbearably painful. It causes 10 out of 10 pain. It wakes people in the night from sleep. It's unbearable. And so patients come to eye casualty. They don't often spend very long going to opticians or floating about with their GP. They tend to come to eye casualty relatively quickly, which is a good thing from our perspective because we can manage it effectively. But it's a very, very painful condition, and it responds very well to treatment in the vast majority of cases. And again, many other causes of many other autoimmune and autoinflammatory conditions and many other infections cause scleritis. And our job is to try and figure out what the cause is at the beginning. Scleritis can also affect the inside of the eye. The top picture shows inflammation along the blood vessels in the eye, typically the veins in the eye. You see the dark red lines, those are the veins in the retina. And then you see these white little patches, and those are patches of inflammation along the veins. And that's quite a characteristic appearance in sarcoidosis. But again, like everything I'm showing you, there are many other conditions that can cause the same appearance. And so there's nothing that's definitely sarcoidosis just looking at that. But that's certainly narrowing things down. So the list of possible causes of these pictures that I'm showing you here is certainly narrowing down to a smaller collection of conditions, and that helps us to focus our tests. The bottom left picture shows a patient who's got sarcoidosis in a slightly deeper layer called the choroid. That's the layer that sits underneath the retina where all the blood vessels are supplying a rich vascular supply of blood to the retina. And inflammation in that layer causes choroiditis, so inflammation of the choroid, and choroidal granulomas. And so these little yellow blobs that you see the optic nerve on the right-hand side. That's what the optic nerve broadly should look like, although it looks a bit fluffy in the bottom right-hand corner, and that's because the optic nerve is a bit swollen in this picture. But the abnormality is the more obvious yellow big blobs off to the sort of left side of that bottom picture, and these are choroidal granulomas. The optic nerve can also be affected by sarcoidosis. And so you're going to be hearing a bit more about that in one of the next talks on neurosarcoidosis. But I spend a lot of time differentiating the different causes of swelling of the optic nerve. So on the left-hand side, you see what looks like a completely normal optic nerve. And in fact, this is how the optic nerve can look. If neurosarcoidosis is affecting the nerve, but it's affecting it 1 centimeter behind the eyeball, closer to the brain, or even in the early pathways within the brain. So the optic nerve in the eye can look normal in optic neuritis. In the middle picture, you see an eye where the nerve itself is very inflamed. So that's optic neuritis, where the neuritis is very localized to the optic nerve head. And we see that in sarcoidosis. And we can see degrees of swelling. And again, this isn't specific to sarcoidosis. Many different conditions can cause this appearance of the optic nerve. Dozens of conditions can do this. And so again, it's our job to try and figure all those things out and get to the bottom of what the cause is and to find where it's sarcoidosis. On the left-hand side, I'm showing pictures from optical coherence tomography imaging. Like I was mentioning at the beginning, this has really revolutionized our clinical practice in the last decade. It gives us incredible insights into the health of these tissues. So in the top left picture, you see a big green circle, and that's telling us that the layers that surround the optic nerve are nice and healthy. They're broadly what we're expecting to see. This one actually is very slightly thickened, so and that's because there is sarcoidosis, but it's further back behind the eye, and it's behind the optic nerve head. And so we can see that there's very, very mild swelling there. And what I'm looking at that gives me that clue is that the black line that you see at sort of top left image, but that sort of funny mountainous map, there's the black line, and that's telling me what the patient's thickness of a particular layer called the retinal nerve fiber layer is at this time. And it's comparing it for me to the green band, which is the average in the population. And so I can see it's slightly thickened compared to the average in the population. But if you were looking just at the slit lamp, this nerve would look normal. So this imaging technology is giving us incredible, unparalleled insight into the health of the nerve and giving us clues as to what's going on behind it. On the right-hand side, you see a top and bottom image that looks very, very different. And this is where a condition which we used to call neuroretinitis. It was a bit of a funny old name that was coined a long time ago, and it doesn't actually make sense as a name. And so now we would call this prelaminar optic neuritis. But this is where the inflammation of sarcoidosis has affected the very topmost layer of the optic nerve head, and it's causing the optic nerve to swell very severely and for lots of fluid to flow out. And that fluid is spreading out from the optic nerve head and it's going under the retina. So one of the questions that was put in the kind of preliminary inquiries about this patient day is, why can it be so difficult to get a diagnosis of sarcoidosis when all the symptoms are there as plain as day? And it's a really good question. And I hope that showing you some of those pictures that I've shown you just above gives you some insight into the challenge that we have. As I say, there are very few of those pictures that are unique to sarcoidosis. The iris nodules are closer to being suggestive of sarcoidosis, but none of the rest of it is. All of the rest of it could happen in 30-odd different conditions. And similarly, the other symptoms that patients with sarcoidosis can first develop, the fatigue, the night sweats, the dry tickly cough, sometimes a productive cough, can be mimicking sarcoidosis, but resulting from something like tuberculosis. People can have urinary symptoms, they can have renal problems, they can have cardiac symptoms, they can have non-specific joint pains and muscle aches. And all of these things can be caused by other autoimmune conditions and autoinflammatory conditions, and sometimes by infections. And people who look after patients with sarcoidosis, and I look after a lot of patients like this, so for me, I find it quite easy to spot somebody who's probably got sarcoidosis and to start narrowing that down. But that's because it's my bread and butter, and I see so many patients like this all the time. But if you are seeing a doctor who sees patients with loads of different conditions and for whom uveitis or scleritis or neuroophthalmology makes up a very tiny part of their practice, that constellation of symptoms and signs is going to be much less familiar. And so this is one of the challenges of living with a rarer disease. It's, you know, it's an uncommon disease. And so it's uncommon, you know, to find care teams sometimes who are seeing a lot of it and who find it quite easy to spot those patterns. And so I think that is one of the challenges that affects all rarer diseases. Can you tell without a biopsy if a lump appears inside your eyelid, whether it's sarcoidosis or not? And the answer is no, we really can't. If it's in both eyes, if it goes with this constellation of symptoms that suggests sarcoidosis to us, if there are other telltale signs at the slit lamp, all of that helps to inform our prior probability that it could be sarcoidosis. And we can be highly suspicious that it's sarcoidosis. You know, I often feel I would put sort of 95% odds on it. But the bottom line is, because rarely the very same presentation can be mimicked by lymphoma, for example, we're still reticent to start the treatment until we've got tissue confirmation, or at least until we've tried to get tissue confirmation. And sometimes it can be so obvious because, you know, there are lesions on the skin that are so suggestive of sarcoidosis, and the whole constellation really could hardly be anything else. But we still prefer in medicine to get tissue where we can, where it's accessible, where it's not presenting a greater harm to get the tissue than not, because it just gives us that long-term confidence around how we're managing it. And as again, we heard, when you're dealing with a chronic condition, you want to make sure you're on the right path at the beginning. So another question was, for a disease which is more commonly associated with heart and lungs, why are there so many people who have it in the eyes as well? Well, I can answer that directly. I'm at St Thomas's now, but I was a locum consultant at King's College London for 2 years before I took up my permanent post at St Thomas's. And during that time, I looked at the medical records held by King's College London. They've turned these into an anonymized resource for research purposes. So there are more than 12 million records, more than 250 million diagnostic tests and results. And we now have this same resource at St Thomas's. And looking across that entire data repository of that hospital dating back to 1998, for all mentions of sarcoidosis, we were able to look at the records, the number of records containing that mention. And drilling into the patients, and it was 0.5% of all King's College Hospital records contained a mention of sarcoidosis. So that's actually surprisingly common, 0.5% out of all records of all diseases held by a major London teaching hospital, related in some way to sarcoidosis. Now, many times that will have been because sarcoidosis was in the differential diagnosis, but the ultimate diagnosis wasn't that. But what you see here, when we drilled into the ones that just had sarcoidosis mentioned, is that the commonest mention is in relation to respiratory conditions. So that's the blue line. But the second most common mention is in relation to uveitis, which is an eye condition. So I would say that this shows us quite clearly that ocular sarcoidosis is probably the second most common organ-specific manifestation. And in the bottom, all the other different colours are where sarcoidosis has caused a neurological presentation, a pituitary presentation, where it's presented with hypercalcemia, which is a renal presentation, or specifically with nephritis, which is a renal presentation, where it's presented with cardiac or muscle, which is myositis. So those are all making up a less common presentation. And what are the common treatments for sarcoidosis in the eye? So I've talked about topical lubricants for the management of dry eyes. We use topical steroids for the management of uveitis, and oftentimes a single 6 to 8 week course will treat acute iritis. We also use topical non-steroidal anti-inflammatories. These are medicines like ibuprofen, but they're created into kind of cousin medicines in drop form. And these can be very good for treating fluid leakage at the back of the eye when it's coming from inflammation nearer the front. So anterior uveitis, intermediate uveitis, with or without cystoid macular edema, which is fluid at the back. Initially, if it's mild, can be treated quite well by these topical drops. We also use intravitreal injections of little implants. Ozurdex is a little steroid implant that lasts for about 3 months. It's very effective at drying up fluid at the back of the eye. It's very good for retinal vasculitis, but it has some downsides. It can cause cataract, high pressure in the eyes, and glaucoma. And those themselves can impact sight and have issues for long-term vision. So we have to carefully counsel people about the risks and benefits of those treatments. Where Ozurdex has worked well, but it's worn off, and we've had to do it once or we've had to do it twice, we then start to think about putting an ILUVIEN implant in. This is another steroid implant, but it releases more slowly and it lasts for up to 3 years. It has the same complications that Ozurdex has. And with all of these, when we put an implant into the eye, there's a 1 in 1,000 risk of actually causing infection or, problems with detachment of the retina. So we have to weigh those risks and benefits up with the patient, and we very much individualize counseling to our patients to try and find the treatment amongst a plethora of options which is going to best suit them. In many patients in my practice, but generally rarely in ocular sarcoidosis, and that's because I work in a very specialized center. So commonly in my practice, we also use oral steroids or intravenous steroids. And this is to try and bring nasty inflammation under control quickly. So we use these for nasty scleritis that's not settling within a couple of days or within a week or so of easier treatments like oral ibuprofen type medicines and topical steroid drops. And we use it in uveitis that's affecting the middle and the back of the eye, so intermediate and posterior uveitis, and uveitis that's affecting the whole lot, so pan-uveitis. And that's because steroids have been around for 50 or so years. They're quite ugly drugs. They have a huge profile of side effects, but they are so effective and so rapid in their onset of action that they are really our top choice still, in 2025 for bringing nasty inflammation under control quickly so that what we're trying to do is avoid damage to these delicate tissues of the eye. But because of those ugly side effects, and there are so many of them, they cause disturbance to sleep, they cause profound tiredness, they affect mood, they cause, therefore, in some patients, low mood, in others, high mood, mania, sometimes psychosis, sometimes severe, dangerous depression, sometimes problems with bones, chronically problems with bones, with osteopenia, which is thinning of the bones, osteoporosis, osteoporotic fractures, with weight gain, difficulty with weight management, with increasing the risk of developing diabetes and high blood pressure and all the health problems that go with those conditions, with easy bruising, just so many different risk factors, so many different complications of steroid use that we end up trying to lower the dose to a low dose of, say, under 10, under 7.5, under 5, as quickly as we reasonably can. And then we also look to introduce other agents that have better side effect profiles. And we call these the steroid-sparing agents. Drugs like methotrexate, mycophenolate, tacrolimus, cyclosporin, azathioprine. These are our go-to agents to try and reduce the amount of steroid that we're giving people in the medium term and long term. And we use loads of those. We have hundreds of patients on those drugs at St. Thomas's, not just for sarcoidosis, but for all the other different conditions that can cause inflammatory eye disease. And then nowadays, for uveitis, if we start someone on steroids, then we start them on a second-line steroid-sparing agent. If their uveitis is still active 3 to 6 months down the line, then we're able to offer them one biologic called adalimumab. It has many different brand names that you may have heard of, like it was originally Humira, but you may have heard of a bunch of the others like Amgevita, and there are just loads of different biosimilar names. But that's it for the NHS-funded drugs that we have available. And so when patients then don't respond to that, we're a bit stuck in many of our different causes of uveitis. Very recently, NHS England have opened up a new pathway for patients specifically with sarcoidosis to enable them to access infliximab. And that's if they have organ-threatening disease that's refractory to these other treatments. And so very occasionally, we access that treatment pathway as well for very rare patients to bring their inflammation under control within the eyes and nervous system. I've mentioned the side effects and complications. I won't dwell on those. So glaucoma is a very important condition to manage. That's the top right. That's where the delicate tissues of the nerve become damaged because of pressure problems with the eye. The pictures on the left are really unpleasant. They're definitely not one to dwell on if you're feeling squeamish. These are extremely rare complications where infection gets inside the eye, oftentimes because of surgeries to the eyes or including intravitreal injection procedures. And they happen less than one time in 1,000, but they can be very damaging for the eye. And inflammation in the nerve can lead to the nerve thinning over time. And we see that in the bottom right as a condition called optic atrophy. So we don't have great evidence around how you can best help yourself in terms of lifestyle, but we do know that patients with a higher body mass index have a slightly more pro-inflammatory state, and across many different autoimmune and autoinflammatory conditions, we see that those with higher body mass index appear to be at higher risk of developing these conditions in the first place. So it follows from that that weight management might be a helpful strategy for reducing the risk of future relapse, but the data is generally somewhat weak. There's an emerging pile of evidence that talks about our diet in the modern world. We see increasing autoimmune disease, and we know that in the last 50 to 75 years, there's been a mass global transition in our diets as compared to the millennia that preceded this, where we had a more hunter-gatherer type diet of whole foods. And so many people are looking to the possibility of diets that reduce ultra-processed molecules that might help to optimize the gut microbiome, that work with whole foods and foods that are made from scratch. And there are theories that this might help to reduce kind of inflammatory relapses and help to control inflammatory disease. And I have some patients who feel that living these healthy diet lifestyles is helping them to control their disease. And I think for a whole plethora of health reasons, it would be a good strategy to consider if you wish to do that, even though the evidence, I think, is very much going to be emerging in the next 2 decades. We know that alcohol can be dangerous for various reasons. Alcohol in excess increases your risk of osteoporosis. So if you're on steroids, that's compounding the risk for you. And we know that alcohol can upset the liver. And many of the steroid-sparing agents have to be metabolized through the liver. And so being on the combination of alcohol and those drugs can be problematic. We know that smoking is pro-inflammatory, and we see that people who smoke are at higher risk of developing these autoimmune and autoinflammatory conditions, including sarcoidosis. So it follows that giving up smoking might be a helpful strategy for helping to control the chronic condition. We see that people who live in with vitamin D deficiency, because of where they're born, because of the weather, where they're born and where they grow up, and because of their genetic ability to metabolize and use and create vitamin D, we see that vitamin D may be a risk factor when it is deficient for developing clinical autoimmune disease and perhaps for having relapses. And it's very easy to take vitamin D supplements and to spend time outside, allowing your body to make natural vitamin D with sunshine. And we know that sleep impacts everything, from our mood and to our cognitive performance. And the drugs can affect sleep, but there are lots of things that we can do in our lifestyle that can mess up our sleep, around sleep hygiene and screens and going to bed at a sensible time and getting the amount of sleep that we need. And I think there are lots of ways in which you can try and help yourself to have good sleep to the extent that's possible with the medicines that you're on. And I think that, really might help your body manage this autoimmune disease. And we know that weight-bearing exercise is really valuable for bone health and strength. So kind of starting to sum up all this clinical stuff, the outlook for vision, I would say, in sarcoidosis is generally very good. If the diagnosis can be made, if you can be put onto treatments that work well for you, and if you can work with your team to be responsive to treatments that you might need, as things change, as time evolves, as you age, as your disease ages with you. And we have many, many more treatments in the last decade than we ever had before. And so I think, I feel really positive about that. And I feel really positive about, the amazing drugs that are coming to many other autoimmune diseases, not yet to sarcoidosis, but I think it will only be a matter of time before we have better access to those sorts of drugs for inflammatory eye disease and neuro sarcoidosis. I want to move on to this other question. Many people's first diagnosis seems to follow a consultation with an ophthalmologist. And yes, that's because oftentimes the eye is the first presentation of a whole host of autoimmune conditions. And we see signs in the eye before they've manifest elsewhere in the body. And for some people, they only ever get signs in the eyes and it never turns into a multi-system condition. And that can be difficult for us because we feel like it looks like ocular sarcoidosis. It shares patterns with that we see in people who've got multi-system sarcoidosis. But because it's not anywhere else, we can't get tissue and we can't prove it. And that's difficult for us because it means that we can't access certain treatments that depend on tissue diagnosis of sarcoidosis as compared to someone who's got the same eye presentation, but it's affecting all their body in other ways, in other organs, in other lymph nodes that can be biopsied. So my research very much focuses on this question of how the eyes serve as a kind of canary in the coal mine for helping us to pick up future autoimmune disease risk and investigating people who first have an eye problem to try and find out what those autoimmune diseases are. And we've got lots of different tests that we do and imaging tests that help us to unwind this. And in my research, looking at kind of the population level at primary care records from 30 million, 42 million people, I look to see when someone first gets eye inflammation, what's the risk that they've previously had a diagnosis of sarcoidosis, for example? These are the little blue arrows. And what's the hazard that they're going to go on and develop sarcoidosis in the future? And what we see is that if you have uveitis, you have maybe a 5-fold, 4.5-fold risk of previously having had a diagnosis of sarcoidosis compared to someone that's never developed uveitis. And if you develop uveitis, you have a 16-fold risk of developing sarcoidosis in the future compared to somebody that's not presenting with uveitis. And so we can see that there's a significant association between uveitis and sarcoidosis. But what you'll get a sense from this long list is that there are many other conditions that also present with uveitis. Ankylosing spondylitis is the strongest association. So we as clinicians have to disentangle what's sarcoidosis and what is not. And there are other clinical presentations. So this is scleritis now. So if you present with scleritis, there's a 2.5-fold risk that you might have a past diagnosis of sarcoidosis, and you have a 3-fold risk in the future of developing sarcoidosis. But again, you see this long list of other conditions that can cause scleritis, and that's what we're trying to disentangle at the beginning. And similarly, if you present with optic neuritis, oh, I haven't put the optic neuritis slide in, never mind, but it's the same story with optic neuritis. So my team are currently looking at the UK Biobank. We're looking at the genetic associations with sarcoidosis. And you can see here in this little purple line that 2.2% of people in the UK Biobank, that's 500,000 people who've given their genetic information for research, have previously had a diagnosis of sarcoidosis when they're first diagnosed with uveitis. And following a diagnosis of uveitis, a further 1% go on and develop sarcoidosis. Now, we know the UK Biobank has a healthy bias, but my team are looking at whether we can use genetic information to help disentangle this. So, for example, in these patients with uveitis, we can look at their genetic risk for multiple sclerosis, their genetic risk for rheumatoid arthritis, their genetic risk for sarcoidosis, and we can try and use genetic information to disentangle what the most likely underlying disease is. And this is new information. We haven't published this yet. It's just in its infancy. But talking to these unmet needs for research, there are many unaddressed questions that we need to move forwards in the future. And I think genetics is really at the very beginning for sarcoidosis because we need bigger studies with more people who have sarcoidosis, more genome-wide association studies before we can start looking more effectively at whether it helps us to predict who's going to develop sarcoidosis in the future. So my team are interested in quality of life. We're interested in health outcomes. Many patients from Sarcoidosis UK kindly contributed to this study that's in progress at the moment, trying to understand how sarcoidosis affects people and the impacts it has on people's quality of life. And we're using that feedback. We've had 22 people already from Sarcoidosis UK in the past year kindly contribute to this effort. We're building a big tool to help us understand the many, many different effects that sarcoidosis and other autoimmune conditions have on quality of life in many different domains of quality of life. And we hope to develop a better tool that could be used in clinical trials in the future that relates to the ocular manifestations of this and other diseases. So I've got loads of people to thank. I work with lots of different colleagues, Andy Cope, James Galloway, rheumatologists that you might have heard of, Alistair Dennison, who's an ophthalmologist in Birmingham, Andrew Dick in Bristol, and others internationally to try and move things forwards. And I would say that if you're interested in this, if you're interested in contributing to your views to how we evolve our research that relates to ocular inflammation in the future, then I'd be really interested to hear from you. I have a patient involvement group, and I'd love to have extra people join that if they're interested to try and shape our research agenda going forwards. Please do feel free to drop me an email. And I've just about got time for 5 minutes of questions. I'm so sorry I've talked a bit longer than I planned to. I have managed to answer 5 of the questions that I received in advance of today. So hopefully that's been helpful to those people that put those questions in. But if you have a burning question that I didn't address, please do put it to me now or in the chat or afterwards. And I'm sure those questions will find their way to me and I'll do my best to answer them. So thank you very much.
Thank you very much. I had hoped to have my face appear on screen, but my video isn't able to work at the moment. So I have one question for you. We have 3 minutes to cover it. So it's actually it's for a patient who lost peripheral vision in their left eye, and they're asking the question: is there some sort of new stem cell technology on the way that could be positive for the future? And then the question that comes from that, I think, is what is the chance of recovering vision if they've lost it?
So I'll start with the end one. So vision loss can be temporary. You can have profound vision loss down to blindness if there's loads of inflammatory stuff in the debris getting in the way. So we see patients in eye casualty who are blind with an acute presentation, but a month down the line, they're back to seeing 6/6 and their vision can be recovered. So some causes of vision loss are treatable and reversible. Where vision loss is resulting from permanent damage to the critical sight sensing tissues, that's the retinal tissue at the macula, with scarring at the macula, or the optic nerve that carries the electrical signal to the brain, that tissue cannot be regrown by the body. And that's because the eyes are an outpouching of the brain. They are part of the nervous system embryologically. And like the nervous system, like the spinal cord and the brain, these tissues of the eye cannot regenerate. They cannot be regrown. What you may be hearing about is early advances in injections and stem cell therapies where people are trying to introduce viral vectors into the eye and stem cells to help these critical tissues start to grow. And those energies are focusing around optic nerve diseases like Leber's hereditary optic neuropathy, where teenagers, typically young men, present with a rapid onset of damage to the optic nerve, and there's research ongoing to see, can we affect the genes, can we switch them off and change them and stop them from doing that before that wiring has become irreversibly damaged. That sort of research hasn't yet translated into inflammatory eye disease research, where the question is, could we one day in the future regrow tissue along the architecture of the wiring that connects the eye and the brain? No one is able to do that yet. Don't believe any kind of quacky clinics in random countries that tell you can come and stay with them for a week and then inject you with stuff and it will allow that to be possible. It's not possible yet. It's very hard for these little cells that you put in the eye to figure out where they should plug themselves in, and they need the right environment, which was perfectly there when you were when you were an embryo. And it's very hard for scientists to recreate that perfect environment for those cells to regenerate. There's also work in trying to regenerate with macular degeneration, like age-related macular degeneration. And that's where you might see advances first. And in that, you've got a perfectly healthy optic nerve, you've got a perfectly healthy choroid, and you've just got damage to the retinal photoreceptor cells. And so the research there is around, can you regrow those little cells, which would be one tiny step in the right direction for these sorts of diseases that we're talking about today. So if we could get each little cell sort to regrow itself and to plug itself in the right way and to connect back up, then one day maybe we could regenerate this whole pathway. But it's nowhere near clinical translation. It's very early days, and there have been decades of research in diseases like glaucoma around trying to regenerate nerves and to do neuroprotection, and the results have been a bit disappointing. But we are at a period with artificial intelligence, making astronomical progress towards discovery. You might have seen, for example, that Demis Hasabian, who was involved in Google DeepMind's collaboration with Moorfields Eye Hospital to improve retinal AI-informed imaging of the retina. He has been awarded the Nobel Prize for biochemistry in recent years because his AI algorithm was able to detangle the 3D structure of proteins. And his AI algorithm decoded 220 million proteins for the first time in 1 year of processing. And to benchmark that, it usually takes decades for molecular biologists to untangle one protein. And so the pace of change in science is on the cusp of radically changing, because if you can understand the 3D structure of a protein that could never be understood before, you can start to perhaps develop drug targets. So I think the next decade is unpredictable, but the future is always bright. And I would always hold on to hope. That's the key thing.
Thank you very, very much for that. That was a fascinating presentation. I've never seen so many eyes, I think, on slides, but there you go.